Yeah, next presenter, you can go ahead.
Good evening, sir.
Good evening.
My first topic is erector spinae block. It's an interfacial plane block providing multidermatomal analgesia of cervical, thoracic, lumbar levels. It can be performed as a single shot technique followed by boluses given intermittently or as a continuous infusion. Coming to the anatomy of erector spinae, these erector spinae muscles comprises iliocostalis, longissimus, spinalis, located parallel along both the sides of the spine from skull to pelvis and sacral region, and from spinous process to transverse process extending to the ribs. It is innervated by the dorsal rami of spinal nerve. Roots of spinal nerves exit through intervertebral foramina and divide into dorsal and ventral rami and supply anterior abdominal muscles as well as the posterior muscles. Indications of erector spinae block includes thoracic surgeries, including breast surgery, cardiac surgery, and lung procedures, abdominal surgeries like laparoscopy and hernia repair, spinal surgeries, mainly lumbar and thoracic region, rib fracture in acute trauma, rib fractures, controlling pain and aiding in recovery. It can also be used in chronic pain management. Uh, Coming to the block technique, the patient position, the patient should be in either sitting, lateral decubitus or prone position. The transducer uses either linear or curved. Linear probe is used in thoracic levels. Curved probe is used in lumbar levels. The depth has to be 3 to 5 centimeter. The transducer position includes paramedian sagittal orientation, approximately 2 centimeter away from the spinous process. After scanning, we have to visualize the transverse process. This transverse process appears as a squared hyperechoic rim with acoustic shadow. We have to avoid pleura in the field. If the transducer is too lateral, ribs will be seen. If the transducer is too medial, thoracic lamina will appear. We have to position the transducer accordingly and have to visualize the transverse process. And these muscles above the thoracic T5 level, there would be three muscles: erector spinae, rhomboid major, and trapezius. Below the T5 level, it will be rhomboid major and erector spinae muscles. The drug is given between the facial plane between erector spinae muscle and transverse process. Insert the needle in plane in craniocaudal direction till the needle tip contacts the transverse process. Inject 1 to 3 ml of local anesthesia to confirm the plane. Complete the block with 20 to 30 ml of local anesthesia. Adequate spread will be seen as deep to the erector spinae muscle and superficial to the transverse process. Thank you, sir. The second, shall I go to the second?
You complete your all the three topics, and then we'll discuss.
Yes, sir. My second topic is Jehovah Witness. The Jehovah Witness religion is a Christian movement founded in the US in 1870s with 6 million members worldwide. Members of this faith have strong belief based upon passages from the Bible that are interpreted as prohibiting the consumption of blood. They believe their beliefs prevent them from accepting transfusion of whole blood or its primary components. They also believe that blood that has been removed from the body is unclean and should be disposed of. The use of procedures that involve the removal and storage of their own blood are often unacceptable. In an emergency situation, a patient's Jehovah's Witness status is unknown. The doctor caring for the patient is expected to perform the best of their ability, which may include administration of blood. Relatives or friends who suggest that a patient would not accept blood transfusion must be asked to provide documentary evidence such as an advance directive. Without this, blood should not be withheld in life-threatening circumstances. If consent for transfusion for a child is refused, and it is felt unreasonable to proceed with the surgery without the freedom to transfuse, an application to the High Court for a specific issue order can be made. This allows transfusion to go ahead without removing all parental authority. Medical social workers can provide assistance in obtaining this action. Where time does not permit application to the court, blood should be given. Failure to give life-saving treatment to a child could render the doctor vulnerable to criminal prosecution. Acceptability of blood products and transfusion related products. The unacceptable blood products include whole blood, packed red cells, plasma, autologous pre-donation. Acceptable includes cardiopulmonary bypass, renal dialysis, acute hypovolemic hemodilution, recombinant erythropoietin, recombinant factors, coagulant factors, clotting factors, albumin, immunoglobulins, epidural blood patch, and cell savers. The management of Jehovah's Witness in the preoperative care includes it is it mainly depends on proper planning of the surgery. The elective surgery should be conducted by a senior team with experience in techniques of bloodless surgery, explaining all the risks to the patients. The planning the surgery preoperatively and postoperatively by arranging beds in the ICU. Advice from hematologists and intensive care physicians of the surgery can of them to be included. Preoperative optimization mainly include we have to pay attention to the hemoglobin concentration, platelet count and clotting studies. We have to stop anticoagulants and antiplatelet drugs if the patient is taking. Optimize the nutritional status of the patients with the use of supplemental enteral feeding or a total parental feeding. We have to consider giving iron either as a oral tablet or an IV injection. Folate can be given like a 20 milligram IV on every alternate days. Vitamin B12 injection can be given once daily. Recombinant erythropoietin can be given. Vitamin K can be administered. Intraoperative management mainly includes a we have to be prompt to stop any bleeding. Meticulous hemostasis with organ beam diathermy can be used. Collagen, cellulose pads, fibrin glues, and these things can aid in any coagulation or bleeding is seen. Maximize oxygen delivery to supplement the patient. We have to avoid venous congestion, high thoracic pressure, hypercapnia, hypothermia. We have to keep the hemoglobin level more than 8 gram per deciliter, keeping the hemocrite more than 18%, performing invasive monitoring to assess the circulatory system of the patient. Consider increased venous blood loss with the mechanical ventilation. The agents we have to give for avoiding the blood loss would be tranexamic acid 1 gram can be given every 6th hourly. Cryoprecipitates like can be given. Prothrombin complex concentrate at the rate of 20 to 50 micrograms per kg can be given. Vitamin K has given us 10 milligram IV. We can also give fibrinogen concentrates, clotting factors, recombinant cell substitutes, and other alternative methods like we are maintaining hemodilution for the patient to reduce the blood loss. Hypotensive anesthesia will reduce the blood loss up to 50%. Regional anesthesia reduces surgical blood loss, but it is contraindicated in the coagulopathic patients. Maintaining circulating blood volume by crystalloids or synthetic colloids. Post-operative care includes the maintaining the monitoring the patient in the proper ICU care, and invasive monitoring can be done, and we can administer iron folate or recombinant erythropoietin in the post-operative period.
Okay.
My next topic is about the jet ventilators. Sir.
Jet ventilation, not ventilator, jet ventilator.
Yes, sir.
Go ahead.
Jet ventilation is a technique that uses a high pressure, high frequency burst of gas to deliver oxygen directly into the lungs. Jet ventilation is an open system that does not completely seal the airway. The main principles include it has an active inspiration. A narrow cannula delivers high velocity jet of gas into the trachea at a rapid rate. The expiration of the gas happens passively as the air flows out of the airway around the cannula and pushed out by the lungs' natural elastic recoil. There would be oxygen and carbon dioxide exchange is facilitated by the turbulent flow or molecular diffusion. Intravenous anesthetics, since the airway is open, inhaled anesthetics cannot be used. Therefore, general anesthesia is maintained with the continuous infusion of short-acting intravenous agents. These jet ventilation is mainly useful in head and neck and throat surgery, mainly for microlaryngoscopy, laryngeal laser surgery, and other procedures involving the larynx and trachea. The catheter provides a clear, motionless surgical field for the surgeon, and there will be lesser vocal cord movements since the tidal volume will be very less. In thoracic surgery, it can be used during tracheal or bronchial reconstruction to minimize the interfere with the surgical access. In emergency airway management, where in can't intubate, can't oxygen scenario, transtracheal jet ventilation can be a life-saving technique to deliver oxygen. In specific medical conditions, like bronchopleural fistula, it helps to minimize the uh, air leakage. Radiologically guided procedures like ablation of liver tumors, lithotripsy, radiofrequency ablation of left atrium. It is very useful since it reduces the organ movement caused by breathing during these procedures. Jet ventilation is classified based on the frequency of the delivered gas and the method of accessing the airway. Classification of by frequency mainly includes low frequency jet ventilation. The frequency would be 10 to 20 breaths per minute. The mechanism is it delivers a gas volume larger than the anatomical dead space, relying on bulk flow for most of the gas exchange. It's similar to the conventional ventilation. Use is typically used for short procedures, whereas a manual device has to be controlled by hand. High frequency jet ventilation, the frequency would be more than 100 per minute. The mechanism is it delivers very small tidal volume, often less than the anatomical dead space. Gas exchange relies on complex principles such as Venturi effect, turbulent flow, Taylor dispersion, and pendulum effect. The use is it most often performed with automated ventilators and used for long procedures such as laryngeal surgery to provide a motionless surgical field. Combined with high flow jet ventilation with conventional low frequency positive ventilation is used as superimposed high flow jet ventilation. The primary mechanisms include Venturi effect, active inspiration, Venturi effect, and passive expiration. Specialized principles include turbulent flow, Taylor dispersion, pendulum effect, and cardiogenic mixing. Turbulent flow, the high velocity jet creates turbulence in the larger airways, which enhances the mixing of the gases. This is particularly seen in supraglottic ventilation, where the jet enters a large space and creates more turbulence. Taylor dispersion, in smaller airways, the inspired gas flows faster in the center and slower along the lateral walls. This helps the diffusion of gas molecules. Oxygen moves from central stream towards the walls, and carbon dioxide moves from the walls towards the center. Pendulum effect, this is the movement of the gas within the lung between areas with different compliance and resistance. After inspiration, gas is distributed from the faster filling more compliant lung units to the less compliant ones. It augments the gas exchange. Cardiogenic mixing includes the physical agitation of lung tissue caused by beating of the heart contributes to the mixing and diffusion of the gases in the lungs periphery. The advantages subglottic. The supraglottic is a tubeless, it provides a tubeless field, but there would be rapid increase in the airway pressure, and we have to rely on the surgeon for adequate ventilation, and there would be any ETCO2 monitoring. The vocal cord movement will be more compared to others. There is no control of FiO2. Transtracheal technique, it is a tubeless wheel, but we have a control over the fraction of inspired oxygen. Disadvantages mainly include it is contraindicated in stenosis patients. The stenosis should be more than the diameter of the catheter. It has to be more than twice the diameter of the catheter. And here the ETCO2 monitoring is again a disadvantage. Subglottic technique, that there would be a minimal increase in airway pressure. The FiO2 is under control, and we can get a ETCO2 monitoring also. But the disadvantages, it is the catheter will be in the surgical field. Complication of high flow jet ventilation includes barotrauma, dry gas, and impact ventilation. Barotrauma can result in pneumothorax, pneumopericardium, pneumomediastinum, subcutaneous emphysema, hypotension, and right ventricular failure. Since gas trapping impacts cardiac output, there is an inverse relationship between gas trapping as well as cardiac. The right ventricle end systolic volume uh, is affected. As the thoracic pressure rises, the venous return is reduced. The right ventricle afterload increases, since due to the compression of the pulmonary vasculature, which increases the pulmonary artery pressure, leading to right ventricular failure and may lead to decrease in cardiac output. Dry gas effect mainly includes mucosal trauma, tracheal necrosis, and atelectasis. Impaired ventilation may result in hypoxia, hypercapnia, and airway soiling are also seen by debris secretions and either by vomitus. Thank you, sir.
Very good. I have no questions on this Jehovah's stiffness and jet ventilation, but your ESP presentation, did you mention that is it given as a single shot block or it is given as a continuous?
We can give both, sir, single shot or either by a cathetering.
What is the technique? How do you do the continuous technique? Did you describe that?
I couldn't get you, sir.
You have to describe the continuous technique also. How will you put in the catheter? How much length you will have to give? What is the advantage, disadvantage? And is it a unilateral block or a bilateral block?
We can give bilateral block also, sir.
That also has to be mentioned. Okay, it can be given as a bilateral block. But what is the disadvantage of giving a bilateral block? You said it's a large volume block. You have to give 20 to 30
a
ml.
craniocaudal distribution will be higher, sir. We can't predict the proper level of this block, sir.
You will require larger volume of local anesthetic. So what is the complication that it
can be seen, sir.
It can
Local anesthetic toxicity.
systemic toxicity. And what are the other complications that can happen in this block? Did you mention that?
No, sir.
I think you didn't mention anything about the complications.
No,
what is the most feared complication and what level you said that you mentioned that the transverse process you have to approach at what level of vertebral column you will do that normally? T4, T5 level, okay, thoracic 4 and 5. And so that if you want a chest wall block, mainly thoracic and lumbar block, you usually choose a T4, T5. But depending upon the surgery, for example, if you want to do give the ESP block for abdominal surgery, you can even come down to L1, L2, okay? Because it is a continuous space from the cranium to the sacral region. So you expect the drug to spread, and you can do if you use the ultrasound probe up and down and see whether what you are injecting is traveling both caudal and capillary. Okay, so that is the mechanism by which it is observing. And as you said, in that space when you inject the drug underneath the erector spinae muscle fascia, it travels both upward and downward to block the spinal nerves which come out of the intervertebral foramen. But the recent MRI studies show that the drug also travels into the intervertebral foramen and goes to the epidural space and produces the block. So that is another point that we have to make. And because you are functioning at the thoracic level, pneumothorax is one of the important complications. It can produce the immediate problem in the patient. Okay? So these points have to be added to the first part. Otherwise, the second and third preparations were fantastic, very detailed and very nice presentation. You can retain that for your answers.
Sir, one suggestion, a small suggestion. During presentation about one small correction, she was telling the infusion can be given. It is a volume block and the space infusion, even with catheter, it should be a bulk block. If you keep infusion, it will not distend the space and the drug spread will not happen. When the catheter is placed,
No, the catheter is mainly given for giving intermittent boluses. It is not
intermittent
given,
bolus is not an
it is,
infusion.
it is not
She
for an
mentioned as
infusion.
infusion. Yes.
It is only for intermittent bolus because you don't have to puncture again and again. You can give it at depending upon the drug that you use, every 6 to 8 hours you can repeat a bolus and continue the block. That is the mechanism by which you do that.